So I'll be speaking on complications of during a Bankart surgery. It's been mostly covered by the other speakers in one way or the other. So I'll be, so the complications or the difficulty we face starts from the portal placement. So make the entry is the most difficult thing for the beginner. So every time you try to make an entry into it, so I myself, when I started off, I found it, my first case, I found it very difficult. I struggled for 30 minutes to get an entry. So actually, John sir had in his talk shown a very simple technique of putting a needle and finding out. So the most important thing would be to find out, put a needle in, feel along the glenoid surface. That is the posterior glenoid. Feel it along the glenoid and then slowly go and poke on the head as well. So this will give us, and the space between the glenoid and the head helps us in a nice entry. When the needle is in, we mark the skin port accordingly and then we can go in. So the other things, once the posterior port is made, is then we go into the other ports, anterior and other ports. So normal difficulty we face are soft tissue insufficiency, like it's been mentioned before, like ALPSA lesions. We have different lesions where because of multiple dislocations, ligamentous insufficiencies, the soft tissue will be inadequate. That's one. Then even if it is inadequate, how to mobilize the soft tissue, that's very important. And then anchor pullouts. So if you put an anchor, it can pull out, especially if it is, you find even that in very young patients nowadays, need not be a very osteoporotic old patient. And in some cases, we have pan-labral, just not the anterior labrum, but also the posterior labrum, inferior labrum. So 360 degrees labral tears we have. And other associated pathologies like slap tears and rotator cuff tears, and especially scenarios like failed Bankart. It's already it's a Bankart failure. How do we manage? So we have gone through the different techniques have been described by the other previous speakers. So I use both in positioning. This is my position for the arthroscopic letargy and the AC joint, the B chair position. And this is the lateral position, the end-on view for the lateral. And this is how I position it. And the most important thing I would say is, see, the way I have figured out is, instead of, as John sir also mentioned in his talk, that he doesn't normally all the way go 2 centimeter here and here for the posterior port. So normally I place, especially in lateral position, the head shifts a little on the lateral side. So it is always better to make an entry slightly in this level. So it need not be a 2 centimeter, because if you actually put the 2 centimeter, you might go too much lateral, and if you or too much medial this way. So a line in line with this would be ideal for a good entry. Coming to ports, as I was mentioning that the ideal way to put the port is with the needle and then inside. These are different ports which I normally use. The posterior ports I've already mentioned, and these are the anterior ports. And here, once we made the posterior port, we are inside, and we have done our diagnostic round. Here, the problem is, as Dr. Shyam mentioned, the others have mentioned, that getting to the 6 o'clock position sometimes can be difficult. So here, the way I do it is, I would always go a little high, and if you keep it on the subscap, the port is on top of the subscap, it kind of hinges, you might not be able to go. It should be slightly high at this level, and we can pass a needle. The needle should go into 6 o'clock, and we can actually see how it is going and mark it. This normally gets me into the 6 o'clock position, and never have a problem getting into the 6 o'clock. So the other ports normally I use are the transcuff port. So transcuff port, it is an anto-superior port, okay, and it is placed behind the biceps. And this is how our transcuff port is made. So here, as we put a needle should be maximum medial toward the glenoid side, and this is how I make it. And this would be my visualizing port and also my working port if I'm doing a slap tear or any plications here. So I also use adaptive cannulas, small cannulas like it should be just around 5 or 6 mm cannulas where it comes to the transcuff. So we are always worried when we do a transcuff port, if the transcuff port is will it heal? Will it end up in a rotator cuff tear? But we published this paper where we did ultrasonic study showing that it actually heals pretty well. So it came out that almost all patients heal up nicely with the transcuff port. Before I go into the next step or more in detail, another most common problem we find is that once we are inside, maybe it starts bleeding. And how to manage this bleeding? So we can't see inside. Once we're inside, so suppose I'm here now, I'm already seeing, visualizing, and because of some reason the pump is stopped, the fluid is stopped flowing, then it starts bleeding inside. What do we do? So here, the best way to manage this would be, so let your cannula, the scope cannula be inside, take it out once, and so that keep pumping the pressure should come in, and then put it back. 2-3 times you do it, you'll be able to take out the blood. Second is, as soon as your posterior port is inside, always put an anterior port, especially if you're a beginner, always put an anterior port, and put a nice cannula, 8 mm cannula there, like the cannula you can see here, and that cannula is always there for you to access and to use. So you can put a shaver to the anterior, let the scope be there. You can even blindly touch both and then take it slightly back, start turning the shaver independently with the suction. It opens up, close up, in 2 minutes it will clear up. So don't panic if it is actually bleeding inside. It is okay, pump can stop, fluid can stop, but we can manage, but never, don't take the scope out completely. Maintain the cannula inside. So open it and close it again 2-3 times. So when fluid starts running, it goes off. So that is one important thing which I have identified. So another thing is, as a beginner, when you start off, the posterior port, the viewing port comes off. So that's why I said the most important thing would be that as soon as your posterior port is in place, put an anterior 8 mm cannula, and that cannula, you can switch the port. You can put the scope to the anterior port, and then you can make a nice entry with your viscing rod again. So don't worry. So the thing is, don't waste around your time. You can do a diagnostic also. If you're a beginner, don't waste your time, because a diagnostic, when you're going around and coming, or posterior going around and coming, there are chances that it's going to come out. So put off your anterior port, and then you can do your diagnostic later. So if your anterior is there, then don't worry, you can always put a posterior port again. So diagnostic round, Dr. Harish has already did a nice diagnostic round. It's very important to do a diagnostic round. Here we pick up slap tears, posterior labral tears, cuff tears, and loose bodies. So here, this is off late, especially in last 1 month I had 3 cases where I had significant loose body. This is a loose body. The loose bodies are normally inside the inferior pouch. So getting that, so once we do a diagnostic round, going into the pouch is very important. And the trick is, how to get this out. So if you, one would be to open the front cannula, 8 mm cannula, and open the shaver so that the fluid start coming out there. That's one trick. Second is, don't worry, because if you're not able to access it too much, keep patting. 2-3 pats on the shoulder will dislodge it, and once it is coming there, you can take it to the anterior. So another thing you find when you take out a problem, you find when you take a loose body would be the soft tissues. So because the chance of when you're taking it out, it gets stuck in the soft tissues. So, and the port through which you're taking through the soft tissue should be wide enough, put a nice artery, open it up nicely, and then twist it around and take it out. That's another thing you do. Here, in difficulties in visualization. So here, if you're doing a lateral position, because if we are in the periphery, we don't have any things like spiders or positioners of the shoulder. So always a visualization is a problem, because the head is like this and the head is always sitting on the glenoid like this. So here, so some people we can put a lateral, not only the lateral traction, vertical traction also up, but even that is not required. You can manage without it. So you don't have to use lot of force to distract the shoulder. I'll just show you the maneuver there. You don't have to distract the shoulder too much. So it is just you have to just push it slightly posteriorly and give us small traction. Okay, even your assistant can arms to do it. So it's not a big problem. Then again, the anterosuperior or a trans-cuff port is the ideal to visualize your anterior to the 6 o'clock and the 6:30 position. See, this is, you can see my assistant actually holding it. So during the release. So this is before and after. This is how you can see, it's pretty, so you don't have to struggle too much. See that it is opening up, just push the head back. So this head back position is also important when you are doing a tie. I'll come to the ties later, when you're doing the anchor fixation and the ties. So yeah, so here that is what I was trying to say. See, it will open up. If there's no traction, okay, you don't have to put a lot of weight there, traction. It's a 6 o'clock position. Anterosuperior port, a slight elevation, pull it posteriorly, and slightly lift up, and you can see that 6 o'clock coming in. So again, talking about soft tissue insufficiency, we have different types of ALPSA, and this is in a classic example. There would be even more worse scenarios. This is one example of how the soft tissue, when we go in a chronic Bankart, that is multiple dislocations are there, or even you can find it even in a fresh tear, with patient coming to after 2 months, you can find this kind of scenario, where you can't find a labrum. So don't worry if you don't see the labrum. Labrum is always there. It can't go anywhere. It is definitely there, but you have to go find it. It will be definitely a little more on the neck. It will be down, and so elevation is the key. So you can start elevating from up, that is from 2 o'clock position, start elevating up and slowly come down to your 6:30. At 6:30, you definitely find your labrum. That is the other end of your labrum. So from that end to that end, definitely you can pick up. So I'm going to 6 o'clock and going up the labrum. I definitely use, especially in this kind of scenarios, I use the RF. I'm careful with it. I go on onto the bone. I use the RF. RF, I use it not only for elevation to a certain degree, but also for, because we should always remember the healing. Why are we doing this? If you actually look at the recurrence rate of a primary Bankart repair, it comes around 10 to 15%. That means to say that at least 1 in 10 patients are going to dislocate again. We have to tell that fact to our patients that if you are doing if I'm doing a primary Bankart repair, your chance of repeat failure would be around 15%. You have to tell them. So question is, why? Because if you look at the re-repair cases, we find that the healing has not happened, and healing has not happened in the right place. So where is it supposed to heal? It is supposed to heal onto the glenoid face. So the anchor should be on the glenoid face, not on the side. And then you should elevate the cartilage. You can see that here I have elevated the cartilage. A nice rim of cartilage should be elevated all around. It should be nicely elevated. You can take it as a ring curate, which can elevate it properly. A thin rim has to be elevated because the tissue will not, soft tissue will not heal onto the cartilage. Soft tissue heals onto the bone. So you definitely have to do that elevation. And when that is done, and you can see slowly I've elevated, in this particular case, I've elevated all the way down, and the tissue is coming up. Take your time in the elevation and don't worry about the bleeding. Then another thing is, because once you start elevating, especially in these kind of scenarios, because you're going along the subscap and the neck, it will start to bleed. Don't worry if it bleeds. The way to stop bleeding would be stop the flow. So don't use the shaver, stop the flow, especially in the anterior cannula. Just stop the flow and it will settle, because the tamponade comes in, it will start settling up. Yeah, and a thorough debridement with the shaver along the neck is important. So now we can see the nice elevation here. So after this is done, okay, then coming to anchor pull-out scenarios. Okay, so here, especially, see, in our, if you look at a dislocation patient, they are much younger patients, but vitamin D deficiencies, not much of activities. So we definitely find poor bone quality in some cases. And especially if it is chronic cases, you can have more of bone quality, which is pretty low. So here, this is a case where I had a anchor pull-out. Here again, the choice of anchors, always the all suture anchors are the best. All suture anchors, because one, the size of some of the all suture anchors in some companies would be 1.7 mm, 1.9 millimeters, which is nothing. 1 millimeter is nothing. So we are talking about 1.7, 1.9. So even if it pulls out, it's fine. Okay, we can put another anchor. Okay, we can drill it a little more into a better bone area, and we can use the same hole for solid anchor, all that we can do. So the choice of anchors should be always, especially in inside intra-articular pathologies, I feel on the glenoid should be all suture anchors, because we don't want any solid material there which can cause any cartilage erosions, and chance of infection are less if you don't have anything other than a thread. So it is always better to have all suture anchors. So here, in this position which I'm going to show you right now is the 5:30 or a 5 o'clock position. So in my cases, I always do a 6 o'clock first, take a bite, I do an inferior capsular shift, then my main tie is going to be at the 5. 5, I normally use a double loaded tape. The suture tapes come, because I find the tapes pretty good, because the tapes take a little more chunk of tissue and helps in a little more, cut through is less, and takes a little more tissue which is pulled up. And it's a solid bite and plication which I get in the IGHL at 5 o'clock position. I normally use a double loaded tape there, and this is a double loaded tape which I happen to use, and you can see that it pulled out. You can see that that is a pulled out portion of that tape. So I took off one, which is a double loaded, removed one, and then again I have used a push lock. Push lock, that is a knotless. I've used a knotless in a slightly higher position. I put a push lock. So now the push lock also failed. Well, how did I manage this? Okay, then I had to shift it to a little more better bone area and put the push lock again. Now you can see that it has come up. So the option when you have a all suture anchor which has failed, you can reinsert and try again in a slight. You can use the same one. If you have not passed the sutures at all, you can try in a different area. If that's not working, in the same hole, you can use a knotless, or you can even go to a better bone. You can medialize it slightly or come onto the face or go slightly up. So this is about if it is pulled out. This is another scenario. This is my 6 o'clock position. I normally use a fiber wire, all suture fiber wire there, anchor. And this is my 5:30. That IGHL plication is the key. So earlier you used to use even now sometimes once I use a lasso, but now I find the easier technique to do this would be, I use a first pass or the scorpion. So the scorpion, you must have seen the elevation which I do. This elevation is quite nice. The elevation, I would elevate it properly. And the scorpion, because I want a deeper bite in the IGHL, and this IGHL bite is the key to your repair. It is not the bump, which we feel that the bump, we create a bump. It is not the bump. The bump is okay, but the main thing is your IGHL. The entire shoulder will reduce if you have a good IGHL plication. The key should focus on the IGHL. So if you get so what I do is, I keep the anchor, my second anchor, first anchor is at 6 o'clock, second anchor is at 5 o'clock, and I have a double loaded there. So my first bite would be a mattress. I use a mattress. That means one pass, the second pass, this should be quite deep in the IGHL, because if you look at the scorpion or something, I find the scorpion good because the profile of the scorpion is much smaller compared to the first passes and all that. So this goes quite deep inside, and the bite is like around 1.5 centimeter in. That is a very nice plication. And if I do a mattress there, the first is a mattress. You can see this mattress coming in now. So that is the first pass, and that is the scorpion. You can see the bite. You can see how nice the bite is deep in, and it goes in and see that second one. That's a mattress. That's a beautiful mattress, and that mattress will actually pull up, and only that one will reduce your head. And during the head reduction, that maneuver which I showed you earlier is very important, that you pull it back. And when you pull it back, the head is reduced, as well as the IGHL. Is coming back to its place. So pull the head back slightly. The head is in the position. Ask the assistant to slightly push it back. When you push it back, it reduces, and the IGHL comes into place, and your plication is going to be perfectly tight. If you tighten it in this position where it has already gone out slightly, it will get tightened in a loose position. So that is the key. The key to avoid a failure is reduce it back and then tighten it. And the second part of my, the first one I've used as mattress. The second one I would use a simple pass. A simple pass, okay, which I had shown here. This simple pass, where what I would do is, that is my bumper. So I'll repeat again. In 5 o'clock, the first is my mattress, a good bite with the scorpion. Second one is a simple suture and a bumper. So I get both my bumper and my plication. So that is I feel that is the key. You can also use the knotless. So now I've started using the tapes and knotless. I'll run a fast video on this. This is my first anchor. That's at 6 o'clock. I'm taking a bite from there at 6:30, and I'm doing the inferior. So I don't tie it up now. I keep it in place. I finish all the others before I come and do it. And you can see the same thing with the lasso. See the deep bite of the lasso, but this is going to be a mattress and a cinch. So I also use cinches at 5 o'clock. That is a mattress there, and the next is going to be a cinch. And you can, the advantage of this also is that you can see, you can put both into a single knotless. So if you are plicating at 5 o'clock, put it at 4 o'clock. So then that is about what are the normal complications. And the other thing is a complication which we feel. So how much of bite? The bite I showed you how much of bite. Lasso, how to take. And so there are instances, if you put a lot of force on a lasso, it can break. It is broken, okay, one of my reused lassos are broken. So we have to go in and take it out. The key is how to prevent the breakage would be, we can do a trial. That means we know where to take a bite. You're pushing it in. Without taking a bite, do a trial. See where it is exiting, where it is coming out. Then you go in and do it. That would avoid tell you the trajectory where it is coming out, then you can catch it faster. And then, as I said, the axillary nerve, okay, so you have to be careful when you're doing the releases down. And anchors also, there are documented instances when anchors or drills past a 6 o'clock position can, but it's overall it's quite safe. Okay, so if you anchor as this way I'm just winding up the last part of my talk, that Remplissages. So here I will not talk about the technique of the Remplissage. I will just say that I normally put the Remplissage anchor in the beginning. After I do a diagnostic, the first cannula inside, and then I put the Remplissage anchor. That Remplissage anchor, you should always put it off first if you're planning to do Remplissage. Putting it later, you find it difficult because the head shift posteriorly, then you can't do it. Then if it's a pretty bigger hill sash, you might have to put 2. This is a technique of intra-articular. So you can see that it's a proper visualization. This is a posterior port. Shift the camera to face this side, onto the side of the glenoid, on the head, and you can pull it one by one and like this. In large hill sash, okay, 2 anchors you can use. Visualization, not a problem. Always, if you're doing it, please put the anchors first, and you can tie it later after you finish later on. So there's also an extra-articular technique. This is where we are already past the sutures through the tendon, but the tie is done extra-articular. That's another technique of doing it. So here, it is a little more demanding, this technique of extra-articular. That is, you come subacromially and then tie. Here we have to visualize as well as do a debridement. We have to be extremely careful with it. So, in soft tissue insufficiencies, there are certain soft tissue insufficiencies. In spite of all this, you are not able to get a good plication. So, this is a advanced technique. This is a basic CME. I will not go into it. This technique is called as the dynamic anterior stabilization, where this is the biceps, and I'm cutting the biceps, and I'm rerouting the biceps through a split in the subscap. That is a biceps in the subacromial space. I'm elevating it nicely, and I'm preparing it with a tight rope, sizing it to 6 millimeters, and through the subscap, rend in the subscap through an anterior port and a cannula. So that's how I'm preparing. I finished the remaining labrum, but this is how we do a rerouting of the biceps. This also can be done in dynamic anterior stabilization. It's a good thing in an armamentarium if you feel that there's soft tissue insufficiency. Rotator indubar closure. So I do RA closures in all my patients who are less than 30 years of age, and this should be done. The trick is, because all of us feel that if you do a RA closure, again, there could be external rotation tightness. The trick is, you should external rotate and then do it. So this is how RA closure is done. So there are different ways of doing it. Dr. Harish had mentioned earlier that you take it with a bird beak. I've done with a scorpion and a bird beak here. And the thing is, so we are looking at a volumetric reduction. It is just not the bumper effect. A volumetric reduction has to be done in the space, intra-articular space, that includes an inferior capsular plication, anterior plication, and anterior also includes an RI. So RIs, if you look at in my patient group, only maybe less than 10% would be having external rotation tightness. Because what I do is, I always external rotate into maximum external rotation and then do this closure. This RA closure is also key to give a good success. And SLAP and other, I'm not going to detail about this, management of SLAP lesions in instability. So the trick is, you do the SLAP repair first through the transcuff port, and then you can do the anterior instability. There could be associated that is rotator cuff tears. So you finish your anterior, that is an anterior plication, Bankart repair has to be done, then you do a pastor repair. So this is a pastor repair, this is a partial articular surface tear. So there's a way of repairing it called pastor bridge. So there are cases. So when you do a diagnostic, don't get worried. So finish your Bankart, then you do your pastor repair. It could be a takedown repair. That means to completely take down, or you can do a parachute or like a trans tendinous technique, which I'm doing right now. In some cases, this is a very recent case we had, very interesting, because you can see there's a pan-labral tear. That means there's a 360 degree, starting from, there's no inch of millimeter of labrum anywhere. So we also have to be prepared about this. That is posterior labrum, anterior labrum, 360 degrees. In this particular case, I've done a bicep stenodesis and done a pan-labral repair. So the different scenarios. And Dr. Harish mentioned about the Kim's lesion. Kim's lesion is a concealed lesion in the posterior labrum. So again, you elevate it. Here, if you have I think one tip I would suggest is, if there is a posterior labrum, I'm just finishing in just a few seconds. The difficulty would be to get an anchor in that place. A high posterior, that means, okay, it should be a little more here. The posterior, it should be on the higher on the capsule to get an access into that anchor placement as well as repair. And hardware complications, it's been mentioned that, okay, avoid metals, avoid anything solid inside is always better. Otherwise, we can have the coconut scraper effect where the cartilage goes off. So better avoid any kind of hardware. Thank you so much for your patient listening.